Ladies and gentlemen, welcome to Close the Gap, the web show where science meets storytelling, addresses health disparities, and we have real conversations about real issues that affect real people. James?
Hi, and welcome to the Close the Gap. On June 5th, 1981, the U.S. Centers for Disease Control and Prevention, known as the CDC, published the first official report on what would become known as the AIDS epidemic. 30 years later, where are we with the epidemic? Where are we with prevention? Specifically, where are we with PrEP, the HIV prevention pill that helps people not to acquire HIV? Who would be leading this conversation other than the scientists who co-discovered HIV as the infectious agent responsible for AIDS? Also discovered the HIV blood test as used today.
Please join us as we welcome Dr. Robert Gallo, co-founder and director of the Institute of Human Virology at the University of Maryland School of Medicine.
Let's get into it with my lead question, Dr. Gallo. So Dr. Gallo, what has changed about prevention since you co-discovered the virus?
That implementation is certainly of recent time with PrEP, for example, is being put to effect. Since the blood test of really was 84, but came out more globally in 1985, knowing the speed of the spread of the virus, that was a big step between what was mysterious and able to understand the epidemic to a great degree. So since the virus was found, I would say the development of the blood test and obviously having therapy available step by step over the years. I guess education is much better. Testing blood before it's transfused to prevent. So I think, it's really implementation now. The PrEP notion is a powerful one. It certainly will work. The problem is implementation.
So this is the part where we ask you guys to ask questions of Dr. Gallo, if you have any. Go ahead for it, Stephanie.
It seems as though we've forgotten that there are other sexually transmitted diseases. And so the implication is for the public that PrEP is the armor, but it's not. And it's giving some people the idea that they don't have to practice safe sex. Because HIV is not the only STD that you're going to get if you don't practice safe sex in communities. PrEP is great, but we have to keep ahead of the fact that we can't send mixed messages to the public.
Yeah, I don't think it's a mixed message. I think it's public education, which brings me to my own questions. I answer with my own questions. Why is there distrust of medicine, medical doctors?
I actually have a question that ties into the question that you alluded to starting out in terms of trust. Certainly I have seen the impact of distrust in the medical community as a strong factor in terms of the proliferation of a lot of these STDs that we're seeing a rise in. Do you have any thoughts, and perhaps others can answer this as well, as to how we as the health community can build trust within the community, and particularly among those populations at risk? That can be for anyone, but that was
Okay. I would let somebody else if they want to or closer to it.
Sure.
I have my thoughts, but please, someone else come forward.
I can answer. When people talk to people and they don't understand what they're saying, that's the problem for them. And a lot of people do not they don't get the research, they don't get the education, because people that are doctors, providers, talk down to them. They don't mean to, it's just how they speak. And this is why I have my job as a peer navigator, because I'm from the community. I can understand what the doctors and providers are saying, but I can also dilute it so they can understand. So you have to get people from the community that looks like them, talk like them, act like them, for them to trust you. No one's gonna open up and say what's wrong with them or what they need, because they feel uncomfortable. And that's just the community that I'm from, and I know this from speaking from facts, that if you feel uncomfortable, if you're in an environment, and it wasn't until I started working for Jackson, working around you people, that I feel comfortable having my voice heard. So therefore, I'm one of the people that I'm talking about, so if you don't have people that will break it down to you and actually talk to you and not talk down to you, then you're not going to get anything. So that's where the medical mistrust comes from, and it's been for years with my community that looks like me.
I understand. We need more contact, though. I mean, you're vital, but someday it should not be that you're vital.
True. But with everything, we need something to bridge the gap.
Yeah, you're not kidding.
Close the gap.
I just wanted to speak more from like a historic perspective where there are things from medical institutions that have been done to marginalize populations that have led to that mistrust. So it's a matter of one recognizing that in certain institutions did things that have been passed down generation to generation that has led to that mistrust. So it's not something that's come out of the sky and people just ultimately don't trust providers. It's just a matter of one acknowledging their truth and things that have taken place, and also understanding it all comes down to meeting the person where they are and being authentic, and again, not belittling their experience or things that they've heard. If there are misconceptions, which at times there are, teach, as opposed to already kind of having your mind made up that this person is either incompetent and or possibly unwilling, because that's not often the case. Instead, there's a lack of patience on a provider's end at times.
I believe that, and I see it too. What has happened is that, not me, I'm more research orientated, but guys in the clinic and doctors, they're spending an enormous amount of time doing paperwork, not seeing your child.
You know, and if you do, like, how a community that is underinsured can have access to PrEP.
Most facilities have what is known as a language line that you can call and speak to a representative who can translate the information between you and the client. And some providers and case management and peer navigators or PrEP navigators do speak other languages. As far as being uninsured, Gilead actually has a program, an advanced and access program that helps people who are uninsured obtain the medication for PrEP for a certain amount of time until they're able to obtain medical coverage on their own. So that's one way to help that population out that is uninsured, and as well as those that speak other languages, there are ways to communicate with the population if there is a language barrier.
Federally qualified health centers are specifically funded as the healthcare safety net. So these are health centers that can see patients regardless of their insurance status. So at those places, Chase Brexton is one of them. I know you're at the Baltimore City Health Department, not a federally qualified health center, but has the means to see the uninsured patients. Total Health Care is a federally qualified health center. So there are centers that can see patients who are uninsured, and there's been a lot of effort to make sure that PrEP is part of one of the services that is provided.
Thank you.
From a provider's perspective, how can we strengthen the way in which we engage patients and having that conversation? Because if our effort, if the goal, if the mission is to, one, meet the person where they are and help people in accessing care, we can't be dismissive, or we can't, again, deem people necessarily unwilling. We can't just stop there, because, again, that conflicts with our overall goal to get people into care and to get people to undetectable, whatever their reality is. It's, again, meeting that person where they are. In addition to, when you think of narrative, there are so many different variables. You can't put Black communities and white communities on the same playing field, because there's a level of privilege within those who are Caucasian, right? So it's not equal. There are so many different variables. There's an educational variable. Does that even tie into like access to healthcare? Absolutely. When it comes to even the thought, when it comes to the prioritizing of it, that in it itself is a privilege. For some, you can very well call off of work and be covered and attend an appointment and be getting your care. For others, you don't have a choice but to continue to work because you have a family, you're of low income, you have low socioeconomic status. So there are certain things that we think are a given for some when they're not.
So it's a matter of how can we really think on a deeper level? Because this whole idea of like maybe some people are unwilling, that's the surface level. If you tease that out just a little bit more, you may come to find that there are other variables. So that's where case management comes in at. How can you really find a navigator or a case manager to really see what other things are at play within that individual's life?
You are just describing the Latina community is very similar to the African American community. On top of the barriers that are already there, which is like the job, like people cannot take off work because then they're going to lose it. Like they don't have sick days, they don't have insurance. Most of our community is undocumented, and I will say that at least at 30%, if not even more, they have a degree of 8th grade or less. So being educated is not a priority about being educated about medical issues.
I think a big part of it, though, also has to do with who has the power to make these decisions, right? Like who's making decisions, who has a voice in the decisions, who even knows that these decisions are happening. And that's where a lot of this, the basis of this comes from, and also just groups of people being treated differently even today. There's systemic racism, there is implicit bias that we all have, and I think that it's important that to answer, there was a question about how do we strengthen the conversation, and I think that as providers we need to really listen, and we need to reflect, and we really need to hear what the people we are working with, what they're saying to us.
But sometimes the docs are really busy, right? And I know scientists that are medical scientists that give I'm told that I'm good at it. I don't know. But a lot of scientists will give talks that I look and I say, gee, the audience, forget anybody here. I'm talking about other scientists. They're really not getting anything. There's a guy's talking way over their head. He's using all kinds of jargon that they don't understand. Doctors in the clinic are used to moving fast. They're overworked, generally speaking, and they're talking only jargon to their peers. They're just in their world. And it's not they're doing it deliberately or cruelly.
Right, but I think in order to be effective, that's a skill, that is part of my job, right? Like if I want to effectively deliver care, I can write all the prescriptions I want and I can talk all I want, but if that's not therapeutic to the person in front of me, that's a waste of our time.
I would really like to know, because in an effort again, this is closing the gap, and you highlighted kind of like a deficiency within providers. They don't have the time to really build rapport with their patients. So what if there was this series of conferences where providers kind of learn how to write the prescriptions and do their paperwork, in addition to building rapport and being able to listen to their patients, because that clearly is why there's a gap. And I don't want to kind of tiptoe around that massive issue, because if we continue to just completely not acknowledge that, we will forever have that gap if providers cannot converse with their patients.
So you think that's around cultural competence?
As far as the provider, there's a lack of cultural competence indeed. So how can we, put efforts towards better equipping our providers?
I think I agree with you, but there's also just a real crunch financially. So, depending on what clinic where you work, you may have 10 minutes to see a patient, 20 minutes for a new patient. I mean, that's impossible. It's completely impossible. So I am constantly running late. I'm constantly behind on my notes, which is also not good. It's not good. It's not good to set up a system to fail. And the way that the healthcare, industry is set up, many people are not happy. Providers are not happy. Patients are not happy. We're not really given the time that's needed to really meet with our patients. So I agree with you, but there's also a system in place that's working against us to make that happen.
Yes.
Yeah, I think that's why talking is important, because they don't know the problem. We don't know the problems on one side sometimes, and you don't know the problems on the other side sometimes.
And also on the education piece, I would just add that academic community partnerships such as this one are essential because many people who will never make their way to an academic medical center in order to get the information that they need as it relates to prevention. But I think that having outlets like this in the community closer to where people live will be hopefully more effective. And I would also add to that faith-based organizations, particularly as it relates to the Black community, really needs to have a stronger involvement with that. And I understand the challenges that are inherent there, but I certainly think that as we move forward, that needs to be an area that we pay more attention to.
Dr. Gallo, where do you think the future of HIV and HIV prevention is going to go?
If we don't get a vaccine, a really effective vaccine, it's going to be continually difficult. I believe in PrEP. Yes, it's obvious. This works. I'm not sure I believe in human beings following it so carefully. That's the problem. It's going to depend on society, economics. It's beyond me, beyond us, beyond scientists. It's not a scientific problem at that level. Vaccine is still a scientific problem. The big science problems, in my view, I shouldn't say this, scientists shouldn't say it, but I'm going to say it. I think the big science problems have been solved long ago. If I'm infected, I'd say soothe and snooze. Leave me alone. Give me a long-acting, safe drug that I only have to take 2-3 times a year. That's a breakthrough. That is what I see happening, that there'll be long-acting, safe drugs. And with a few pills a year, you'll be fine. That's what I think will happen, I believe can happen.
Thank you, everyone.
Thank you.
Well, that's it, ladies and gentlemen. Look at the resources on the bottom of our page for further information. If you have any questions for us, please find us on Facebook. If you have any questions for our panelists, please tag us on Facebook. And if you want to be on our couch, hit us on Facebook. Everyone, thanks for coming in today. And that's a wrap.